You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
Here we go. Another middle-aged person, 65-year-old woman with type 2 diabetes since age 48, childhood onset overweight, postpartum obesity in her 30s, and history of preeclampsia. Diagnosed with uterine cancer last year. She had a THBSO 4 months ago, doing well. Post-op challenges include obstructive sleep apnea, which is recognized in the hospital, very common, and poor mobility due to osteoarthritis. Regimens since surgery: metformin, dulaglutide, valsartan, hydrochlorothiazide, or rosuvastatin 20. These are her key data. You could see, again, very significant obesity, BMI 48. GFR is looking okay. The UACR is 50, so not too bad, but the LDL is elevated for sure. Blood pressure is also elevated. So which of the following is the best next therapeutic step for this individual? So this is excellent. So first of all, you guys are obesity focused. You're right on.
Yep.
Now, the reason why switching to tirzepatide, a highly potent agent, is the first step is just because she recently had surgery.
Yeah.
She can't, referring to the weight loss program actually isn't a bad idea right now, but she's going to have to wait anyway. She'll probably have to wait, depending on the program, 6 to 12 months. And in addition, I think I have this all written out for you. In addition, if you look at the third bullet, even though we know that bariatric surgery is a great option for her, she would be advised to reduce her weight before surgery. So remember that people should be engaging in whatever therapy they can access for obesity management on their way to surgery. And they're often waiting up to a year, depending on their situation. So I think everybody's right, which I love. I love when everybody's right. A couple points here that I wanted to make. And so first of all, when we titrate the agent, we have to understand what kind of benefit we will get with titration. In diabetes, and actually in my practice, I do manage obesity without diabetes. I don't do forced titration, even though for insurance coverage, you have to do forced titration for non-diabetes obesity to get it covered, at least to get to what they consider a stable dose, which I think tirzepatide, they're now agreeing on keeping somebody at 7.5 milligrams to be chronic. But I don't like forced titration. I actually like slow titration because I want people to tolerate the drug. However, I'm fully aware that until I get to a certain dose, I won't see as much benefit. And so here's an example, like dulaglutide is considered now lower potency. And you can see that when you go from 1.5 to 4.5, you're seeing maybe the A1C change will be about 0.5%. So that's not a big deal. And when you look at weight, I think is the next one, right? Is that the weight loss? Or is that still A1C, actually? Sorry. Let's go to the next one. So A1C, you don't get too much more. But when you look at weight, you see a little bit of benefit when you go from DULA to 1.5 to 4.5. But maybe just, we're talking about 2 kilograms. So consider that. Sometimes you have to just say, we're not going to get there with this drug. Titrating you up to the max dose. I know you tolerate this medicine, but switching you to a higher potency drug is often the case, is often what we need to do. And you can see from going from sema 1 to 2 milligrams, you're definitely seeing a difference in kilogram weight, maybe 4 kilos there, 4 or 5. But you have to sometimes cut your losses. One thing I wanted to ask from the last case, because we mentioned SGLT2 inhibitors as the first line unless there are side effects, right? And we also talked about how
Unless what?
unless there are side effects or contraindications.
Contraindications.
Sorry, contraindications.
Yeah.
So we should talk about that because we really don't want to give up on some drug classes too soon or sort of overemphasize what are relative contraindications. So for SGLT2 inhibitors, type 1 diabetes in my practice, it's a relative contraindication. I know for a cardiologist to prescribe, I respect you having it be an absolute.
Yeah.
Right? But when we see type 1 diabetes with CKD and heart failure, we actually typically prescribe.
Nice.
And then it's one note, minor point. But the other, what about, recurrent UTIs? That comes up a lot. I don't know how you handle that in somebody with heart failure.
Yeah, I mean, if someone's had, so one of the risks of SGLT2 inhibitors is urinary tract infections and especially kind of mycotic infections. Glucose in the urine is a really good nidus for infections of all kinds, especially, those. And so I would say for us, if someone has had recurrent, UTIs or pyelonephritis, then maybe you kind of veer away from that. But if someone had a UTI, 5 years ago and has never had anything, I wouldn't be dissuaded from that. You have to be vigilant, counsel them about, good hygiene. But I certainly agree with your point that we're trying to get these highly effective therapies on board. I mean, we've spent the morning here really highlighting the importance of these therapies, that they really are cardio-renal protective therapies. And so, you really want to try and make sure all the patients who might benefit from them can get on.
I'll go a step further on that. I'm not sure that the term UTI should have ever been included with SGLT2 inhibitors. I don't really think that there's any good evidence that SGLT2 inhibitors are associated with true urinary tract infections.
Yeah.
There's some epidemiology that shows that it reduces your risk. So it's very confusing because it increases urinary flow, right? Which we know.
Yeah.
So I think it's about hygiene and probably if somebody's functional, I think functional status makes, if you're sitting more than walking or moving around during the day, then your risk is higher.
Thanks for watching. If you found this discussion valuable, be sure to subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.